The title of this video is Increasing Retention on a Denture with a Severely Resorbed Ridge. I think you will agree that these are severely resorbed ridges, and if implants are going to be done, there's going to have to be significant bone augmentation in the sinus, and you can see the situation on the lower where probably the mandibular nerve is exposed, and that might be the ideal treatment on this patient. And her chief complaint is, my dentures won't stay in, and I'm hoping that a new set will fit better. Let's look at the patient information. We're dealing with a 70-year-old Caucasian female, and she's worn her dentures for over 50 years, which means that she got them as a late teenager or in her early 20s. But in planning the treatment plan, I think we need to think in terms of what is a financially appropriate dentistry. This lady works 20 hours a week at a minimum wage in a deli in a grocery store. Her only other income is Social Security, and obviously she has no dental insurance. So the aforementioned treatment options really are not available to her. But what do we have to offer? Here we see the severely resorbed ridges, both in the maxillary arch and the mandibular arch. And she has a vestibular depth in the maxillary arch of about 7 millimeters. We can see on the left her current set of dentures, and you will notice that she is in occlusion. For if she tries to open her mouth, these tend to flop out. And on the right, you see her with the dentures in place. We can see the wrinkles at the corners of her mouth, and she is unable to smile without these dentures coming out. Now, what can we do to help? First of all, we're going to take some triad material, which you can get from any dental dealer. And by going in there after scoring the flange on that, we're going to go ahead and cure that with a curing light. And then we're going to take the triad material and roll this up and go ahead and increase the depth of the flange on this by at least 5 millimeters. So it was 7 to start with, so now we're hoping to have a flange of 12 millimeters when we're through. So you sort of just border mold this with your fingers arbitrarily, and then after curing it, go ahead and finish it down. And then we try it into the mouth before surgery, and obviously it's not going to go to place. But now we can see how much we're going to be deepening the vestibule. And here is the stent denture, or the denture after all of this is added, and now we're ready to proceed with our surgical procedure. And what we're going to do is a periosteal separation technique, that a classic article done by Dr. Herman Korn back in 1962. So let's talk a little bit about that. Typically that is done in the mandibular arch, and you can see in this adolescent patient that there is a minor amount of gingival recession, and certainly soft tissue grafting down here could be indicated. But instead, we went in and did the periosteal separation technique, and this is what we did. We made a split thickness initial incision at the mucogingival junction, and then we did a split thickness flap down about 5 millimeters, but the key is we expose bone in this apical area where that will scar and be the depth of the vestibule. And you'll remember Harry Bohannon did the lead shot technique and found that if you do not expose bone, the vestibule will completely reform. So here we see a 3-week post-op, and we can see where we now have the depth of the vestibule, and by removing and deepening the vestibule and getting rid of any preliminary frenal attachment, that tissue will creep right up. So the surgical principles that we're going to use in this case are a split thickness flap for about 5 millimeters and then exposing bone. We're going to make the incision from the hamular notch to the hamular notch. This is the initial incision. And now we're beginning to elevate the tissue, and we're going to expose considerable bone and increase the vestibular depth from 7 millimeters to 12 millimeters. But by removing this nasal spine, the denture will have a different appearance in this maxillary anterior area. So the incision is made, as I said, from hamular notch to hamular notch because we want increased vestibular depth, not only in the anterior but also in the posterior as well. I mentioned removing the nasal spine. Here we're using a diamond to do that. Now we're ready to go ahead and insert the denture, and because we have created a deeper vestibule, the denture will go to place. But remember, the triad material was put on there arbitrarily, so it is not going to fit. So then you go in and use something like Co-Soft to go ahead and reline the denture, as we're doing here, and now the denture immediately has significant retention. The patient can very well tell what has been done. Then going in there and trimming this up, and notice in the nasal spine area where this denture goes further to place, and you can see the soft liner that is in place. Then the denture is inserted and the patient is told to keep the denture in all the time for the next couple of weeks, except taking it out perhaps once a day to clean it. It's been tried to use a softer material up here, but unless you actually have something hard up there to stabilize this, it's not going to work. So the vestibular depth has been increased from 7 millimeters to 12 millimeters. Now here we see the 3-week post-op on that, and look how we still see some healing tissue up there. And then we see a 6-week post-op, and you still see a little of the residual soft tissue that hasn't healed. So here you see we're removing the excess tissue with the radiosurgery. What is radiosurgery? First of all, this is completely different in concept from electrocautery or electrosurgery. So let's look at the differences. Electrosurgery uses a lower frequency, it has much deeper penetration, generates considerable heat, and you get significant tissue destruction. However, with radiosurgery, this is more of a laser-like wound. It is a higher frequency, shallower penetration, generates minimal heat and minimal tissue destruction, and makes it the perfect instrument for gingivoplasty or removing excessive tissue, as we have done in this case. There are many units made by the Elman Company, but this is the original unit that was made back in the 1960s and will do anything that we need to do in periodontics. There is a video on this, the clinical use of radiosurgery, where we will go more in depth in principle and show multiple areas where this can be used. I would urge for you to look at that video. All right, here we're removing the excessive tissue, and you will see the tip on the left, and these are multi-use tips that can be sterilized, and we can see on the right where that tissue that you see on the top right has been vaporized, and just like with the laser, there's no bleeding and no damage particularly to the nerves and so forth, and that heals very, very rapidly. So here's our final result, and you will see where we had a 7 millimeter vestibular depth, and then you can see the white line up there where we've increased the depth to 12 millimeters. As you move distally in the mouth toward the hamular notch, because of the zygomatic arch, you really cannot deepen the vestibule that significantly, and you will see that on the final denture when we come to that image. So this procedure improves retention, and it improves facial contours, and it eliminates wrinkles. So this is where we started on the left, and you can see how shallow the vestibule was, and now we can see on the right, and notice the white scar in the depth of the vestibule. This was where bone was exposed. The patient has now been wearing this particular The patient has been wearing this particular denture for several weeks, waiting on complete maturation before going ahead to the final fabrication. And so here is that particular denture in place. Here is the final denture, And I think you can see from the black line on the facial how much we've deepened it in the anterior area. But please note, as you move distally, we were not able to deepen the vestibule to the extent that we would like to because of the zygomatic arch. Obviously, getting a well-developed post-dam in this new denture was another key factor in it being successful. Now let's look at what we've accomplished. On the left, you see her preoperatively holding the denture in place, slightly smiling, as we said, because the denture will come loose, and notice the wrinkles at the corner of the mouth. On the right, you can see how the wrinkles are diminished. You can see how pleased she is, and having this done, she wanted the whitest teeth that she could have, and by golly, we gave it to her. Before showing her testimonial and how she likes the dental work that we did for her, you need to be aware that we placed a single implant in the mandibular arch, and that will be the subject of this video. So let's now see what she has to say.
And I'm so confident in this denture and the stability of it. I'm going to try to eat some nuts, which I haven't been able to eat for years. And it's easy to do. I can eat the nuts, and my denture isn't even moving. And the way they made the denture, the food particles don't go underneath of it. So I'm very pleased. I'm very happy.
Yes, the patient is very happy, and remember how financially compromised she was, and look at what a great result and satisfaction we gave her by a simpler, easily accomplished treatment plan. And I would like to say thanks to the dentist that we worked with on this case.